The next two chapters we're going to talk about are going to be medications affecting the reproductive tract, which is chapter 27. Then we'll move on to diabetes mellitus and then endocrine disorders. Objectives for this chapter: explain the mechanisms by which estrogen and progestin prevent conception, discuss the uses of progestins in the therapy of dysfunctional uterine bleeding, identify the role of the female sex hormones in the treatment of endometrial cancer, identify the reasons for pharmacotherapy with androgens, describe the pharmacotherapy for erectile dysfunction, describe the pharmacotherapy of benign prostatic hyperplasia. For each of the classes listed, identify representative drugs and explain their mechanism of drug action, primary actions, adverse effects, contraindications and precautions, and interactions. Estrogens are going to be the first ones we'll talk about. Conjugated estrogens and estradiol, which is Premarin. Growth and maturation of the female reproductive tract is the action of these. Secondary sex characteristics: follicle cycle, blocks the bone reabsorption and reduces low density lipoproteins, and high levels of estrogen will help treat testicular cancer. Therapeutic uses: contraception, acne, relief of moderate to severe postmenopausal manifestations, prevention and treatment of postmenopausal osteoporosis. So this will help reduce fractures, dysfunctional uterine bleeding, and palliative treatment of prostate cancer. Complications: endometrial and ovarian cancer. So this is going to be used more in the postmenopausal therapy. Progestin can be added to the estrogen to help prevent the types of cancers. So the client needs to be educated on reporting persistent vaginal bleeding if the client still has a uterus intact, and then having endometrial biopsies every 2 years, and then a pelvic exam yearly. As we talked in class, if there's not an abnormal pap smear, then they can have their paps done every 3 years, but they'll have a breast exam done by the provider at their physical. Risk of estrogen-dependent breast cancer. So this, once again, is more postmenopausal clients who use estrogen with progestin. So it's kind of a double-edged sword. You're trying to prevent endometrial and ovarian cancers, but then to take progestin with the estrogen, but then you run the risk of developing the estrogen-dependent breast cancer. So you need to rule that out first, that it's not currently present, and then having them do self-breast exams regularly, their yearly breast exams by a provider, and then periodic mammograms. Embolytic events: so this is your myocardial infarctions, pulmonary embolisms, deep vein thrombosis, and stroke. It's typically the females over the age of 60 that are going to be at more higher risk for the MIs and coronary heart disease. So they need to monitor for any pain, swelling, warmth, or erythema of the lower legs. This will be an indication of a DVT, which could turn into a PE if they complain of shortness of breath. They need to reduce the risk of cardiovascular disease, which they could do this through diet, exercise, and then also avoiding all nicotine products. So you may have to help them create a smoking cessation plan. Contraindications: pregnancy risk category X, heart disease, atypical vaginal bleeding, breast or estrogen dependent cancers, thromboembolic disease. Precautions: breastfeeding prepubescent clients. Interactions: warfarin, phenytoin, corticosteroids, smoking, anticoagulants, oral hypoglycemics or thyroid medications. Nursing considerations: need to instruct them not to apply the patch to the breast at all. They need to be applied to the trunk. They need to report any menstrual changes. So if they're having difficult periods, they're not having periods at all, or any breakthrough bleeding or any breast changes, they need to notify their provider. Then report any swelling or redness in the legs, shortness of breath, or chest pain. Discontinue prior to surgery that requires immobilization because they're going to be at higher risk of a DVT or PE developing. Okay, then the progestins, methodrox, progesterone, and northodrone. This is fetal growth and development and maintain pregnancy, menstruation. Contraception, these are therapeutic uses. Menopausal hormone therapy, vitro fertilization and prevent preterm labor, dysfunctional uterine bleeding, amenorrhea, endometriosis, and advanced cancer of the endometrium. Okay, complications. Common ones are going to be depression, tenderness of the breast tissue, reports of feeling bloated. Breast cancer, this is when it's going to be combined more with the estrogens, so they need to do the regular breast exams and get mammograms. Thrombolytic events, MIs, PEs, thrombophlebitis, stroke. So we need to highly encourage these clients to quit smoking, and then monitor for pain, swelling, warmth, or erythema of the lower legs. And if they start having chest pain or shortness of breath, they need to notify their provider. Any breakthrough bleeding or amenorrhea, so anything abnormal they need to report. So breakthrough bleeding is bleeding that occurs in between periods, and then amenorrhea is no period at all. Edema, we need to monitor blood pressure, eyes and nose, daily weights, because this could lead to heart failure if this continues. Jaundice, we're going to monitor liver enzymes and then monitor for the yellowing of the skin or the sclera of the eyes. Migraine headaches need to be reported, and then it can cause birth defects, spontaneous abortion, so they need to let the provider know if they are planning on becoming pregnant or that they suspect that they are pregnant. Contraindications, vaginal bleeding, thromboembolic disease, cardiovascular or cerebral vascular disease, breast or genital cancers. Precautions, seizure disorders, asthma, cardiac disorders, migraine headaches. Interactions, carbamazepine, phenobarbital, phenytoin, rifampin, corticosteroids, and anticoagulants, and smoking. They need to apply this as directed and then notify the provider once again if pregnancy is planned or suspected. Or hormonal contraceptives, estrogen, progestin, estradiol, and northodrone. And then there's some progestin only contraceptives. Make sure you review that sheet that I gave you on the biphasic, monophasic, triphasic, and progestin only. Transdermal patches can be applied, and you change those out daily. Nuva rings, you'll change. Parental is the depot shot. So remember, we give this IM, and we give it typically in the deltoid or the ventrogluteal. And then you have your implants. Your Norplant is one of the examples. Or you have the Mirena that they put in as well. Action is to stop conception by preventing ovulation, thickening the cervical mucus, and alter the endometrial lining to reduce the chance of fertilization. So this is used to help prevent pregnancy. Complications are going to be thromboembolic events, hypertension, some monitoring blood pressure to reduce that. Your thrombolytic events, which we talked about, stop smoking, and then reporting any warmth, edema, tenderness, or pain in the lower legs. Breakthrough or irregular uterine bleeding. So they need to make sure that they're not pregnant if they've missed more than one period. And then they record the duration and frequency of the breakthrough bleeding. Breast cancer, oral contraceptives can increase the risk of breast cancer. So do not give, obviously, to clients who already have breast cancer. Hyperglycemia, monitor glucose in clients who have diabetes mellitus, and then adjust their antihyperglycemics as needed. Hyperkalemia, this is then combined with over-the-counter that contains drospirenone. So do not use anything over-the-counter that contains this, because then they're at higher risk for hypokalemia, especially if they have impaired kidney function and adrenal insufficiency. Contraindications: pregnancy risk category X, smokers, and if they're older than 35, thrombophlebitis and cardiovascular events, breast cancer, and abnormal vaginal bleeding. Precautions: hypertension, diabetes mellitus, gallbladder disease, uterine lymphoma, seizures, and then migraines, headaches. Interactions: carbamazepine, phenobarbital, antibiotics, phenytoin, rifampin, warfarin, and oral diabetic medications, theophylline, and imipramine. Nursing considerations: take medication 21 days followed by 7 days of the placebo. Make sure you're educating on those missed days. Extended cycle or oral contraceptives taking longer, so the 84 days or continuously. They need to stop smoking and then report any of those signs of a PE or DVT. Okay, also on your progestins, when it's being treated for dysfunctional uterine bleeding, they need to start progestin 5 days after the onset of their menstrual cycle, and then just continue that for the next 20 days with the progesterone. Okay, then the next group is the androgens. Testosterone, so the development of sex traits in men, production and maturation of sperm, increase in skeletal muscle, and increase in the synthesis of erythropoietin. Therapeutic uses are deficiency of testosterone, hypogonadism in males, delayed puberty in boys, androgen replacement and testicular failure, postmenopausal breast cancer, and muscle wasting in male clients who have AIDS. Okay, complications: androgenic effects. So this is in female clients. This is going to cause irregularity or cessation of menses. Hirsutism, which is the hair, facial hair. They can have weight gain, acne, lowering of the voice, growth of the clitoris, vaginitis, and baldness. In the males, they may have acne, priapism, which is persistent and painful erection of the penis. So please correct that in your notes. Increased facial and body hair and penile enlargement. So they might discontinue the medication to prevent permanent changes. Advise clients to possible medication effects and then report those as soon as they occur. Epithelial closure. So this is going to be in boys. It's going to reduce their height. So we need to make sure we monitor the epithelial with x-rays. Cholestatic hepatitis and jaundice. So once again, monitoring those liver enzymes and looking for signs of jaundice. Hypercholesterolemia. So medications can decrease the good cholesterol, which is the high density lipoproteins, and increase the low density lipoproteins, which is the bad cholesterol. So we need to monitor cholesterol levels and then just adjust their diet, increase exercise. Increase in the growth of prostate cancer. So do not give, obviously, to men that have prostate cancer, and then monitor that. And we can monitor that by drawing PSAs to look for an increase in that lab result. Polycythemia, monitor hemoglobin and hematocrit, because this is when they have too much red blood cells, and they may need some drawn off. Edema from sodium in water. So weight gain, swelling, in the extremities, they need to notify their provider because it could be discontinued. The last one, high potential for misuse. There's high risk groups, so you just need to keep an eye. They may have behavioral changes. So just keep an eye. Complications, pregnancy risk category X, avoid during lactation, males with prostate cancer, liver disorders, severe cardiac disease, interactions, oral anticoagulants, and insulins and anti-diabetic agents. Nursing considerations, there is gel formulations. There's IMs for large muscles and just need to rotate. Barrier method, monitor female clients, sorry. And then barrier methods of birth control, reduce cholesterol in diets, watch for the misuse of androgens or the testosterone, and then doing daily weights. The one thing I forgot to talk about under the progestins, and when we talk about pregnancy, we need progesterone to have the egg implant. So if we are, as females, if we're not pregnant, then the progesterone levels will drop significantly after when the period starts. If pregnancy is achieved, then those progesterones are going to stay elevated to have the fetus grow, maintain the pregnancy. Then your 5-alpha reductase inhibitors. This is Proscar, phenylestride. This is decreased usable testosterone, reduction of the prostate size, and increased hair growth. So it has 2 uses: benign prostate hyperplasia (BPH) or male pattern baldness. The only difference is that the amount of the medication, depending upon which one of them you are treating. Complications can be decreased libido, ejaculate volume, so they just need to notify the provider, as well as the gynecomastia, which is the enlarged breast on the male. Contraindications, pregnancy X, and then medication hypersensitivity. Precautions, liver disease, nursing considerations, therapeutic effect 6 months or longer. Pregnant women do not handle it. Even if they wear gloves, they are not to handle it. The females are not to come in contact with the male sperm at all either, because it can be found in there. And they cannot donate blood. Okay, then the next group is alpha-1 adrenergic antagonists. This is your Flomax, your Cardura, and your Hytrin. Out of those 3, if a male has high blood pressure and they're not on medication at that time when they find it, they could try putting them on Cardura or doxazosine, because it works. It double duties. It helps with BPH as well as with helping decrease blood pressure before they add maybe a beta blocker, calcium channel blocker, ACE inhibitor. So the actions of these medications are to decrease obstruction of the urethra by relaxing the smooth muscle, and then a non-selective is the vasodilation. Therapeutic uses is BPH. So complications, hypotension, dizziness, nasal congestion, sleepiness, faintness. So just having them monitor their blood pressure, not getting up quickly. And this is going to be more likely with those non-selective medications. So the Hytrin and the Cardura would be those 2. Slowly rise, and then not operating machinery or driving until they know how they're going to be affected. They also can have problems with ejaculation, so it could be failure, decreased volume with Flomax. Then contraindications, medication sensitivity. Doxazosine can be liver impairment, females of childbearing age. Precautions, tamsulosin, hepatic or kidney impairment, and interaction Centodine. Nursing considerations, monitor blood pressure, administer medication. So the tamsulosin 30 minutes after a meal, terazosin at bedtime, and doxycycline at the same time each day. Then the last group is the phosphodiesterase type 5 inhibitors. This is your Viagra, Cialis, Levitra. This is going to enhance blood flow to the corpus cavernous and the penile erection. And this is used for erectile dysfunction. So complications, there's common adverse reactions, headache, flushing, nasal drainage, congestion, and nausea. Priapism is the painful erection that lasts more than 4 hours, so they need to seek help if that occurs. Sudden hearing loss, discontinue the medication if that occurs. So contraindications are going to be any nitrates, because you already have the vasodilation going on with the medication itself, and then you add nitrates on top of that, you're going to vasodilate even more, and it can bottom out their blood pressure. Precautions, antihypertensive medications, grapefruit juice, interactions, organic nitrates, conazole, erythromycin, centodyne, ritonavir, grapefruit juice. So nursing actions, or considerations, administer orally before sexual activity. It just depends on which medication they're taking, on how quickly that they need to take it, or how far in advance they need to take it to be ready for sexual activity. Cialis can be taken on a daily basis, or taken just prior to sexual activity. Just remember that other medications, such as your antihypertensive, a lot of your antipsychotic medications affect penile erection or erectile dysfunction. So these men may just need help in that department due to other medications. It's not that they physiologically have that problem.